Thank you for viewing this program. This module discusses external beam radiation therapy for prostate cancer. Prostate cancer is the uncontrolled growth of gland cells in the prostate, a small gland just below the bladder that surrounds the urethra or urine channel. This common cancer is detected most commonly by the prostate-specific antigen, or PSA, blood test, and a digital rectal exam, or DRE. The diagnosis is confirmed by a biopsy, which allows doctors to look at the prostate cells under a microscope. The treatment for prostate cancer depends on the stage or extent of the disease, and different options may be considered for different stages of prostate cancer. In general terms, prostate cancer may be considered localized or organ-confined when it is felt to be entirely contained within the borders of the prostate. Locally advanced when there is suspicion or evidence that it has escaped through the capsule of the prostate or into nearby structures. Recurrent when it has previously been treated and then comes back. Or metastatic when it has spread to other parts of the body away from the prostate. Localized or organ-confined prostate cancer means that there is no clear evidence of cancer spread outside the borders of the prostate at the time of diagnosis, based on the information available, meaning the PSA, the digital exam, and the biopsy report. There are many treatment options available for localized prostate cancer. Accepted standard options include active surveillance with possible delayed treatment, surgery, called a radical prostatectomy, and two types of radiation, external beam radiation and brachytherapy. The rest of this module discusses external beam radiation in more detail. Other treatments for prostate cancer not available at all centers include cryoablation or freezing of the prostate, high-intensity focused ultrasound, or HIFU, and others. Locally advanced prostate cancer means that there is evidence of cancer spread outside the borders of the prostate at the time of diagnosis. For locally advanced prostate cancer, initial treatment may involve surgery and/or radiation therapy, usually combined with hormone therapy before and/or afterwards. As you can appreciate from the previous slides, external beam radiation has many roles in the treatment of prostate cancer. For localized cancer, it can be used as primary treatment for cure. For locally advanced or high-risk cancer, it can be used in combination with hormone therapy, also with the goal of cure or at least control as primary treatment. It may also be used in this setting after surgery, called adjuvant therapy. Sometimes cancer can recur or persist after other treatments, and external beam radiation can be used in these settings also, as so-called salvage treatment. Radiation therapy uses high-energy X-rays or other types of radiation to kill cancer cells. There are two forms of radiation treatment. External beam radiation therapy, or EBRT, uses a machine outside the body called a linear accelerator to send radiation toward the cancer. For treatment of localized cancer, patients typically receive treatment once a day, 5 days a week, for a 6 to 8 week period. Brachytherapy, in contrast, refers to the introduction of radioactive sources, or seeds, directly into the prostate itself. Details of brachytherapy are covered in a separate module. The energy from radiation works to kill cancer by interrupting the structure of DNA, which is the genetic building block for cells. This prevents the cancers from dividing and reproducing, and eventually leads to the death of cancer cells. Due to the complex ways in which radiation can effectively kill cancer cells, one must be aware of any potential interactions between medications and radiotherapy. Ensure that you review any prescribed medication or supplements with your physician prior to starting radiation, as some may interact with the radiotherapy and may not be safe to take in conjunction with therapy. The radiation oncologist will individualize treatment to suit an individual's prostate cancer diagnosis. Using an advanced computer program, the oncologist can focus the radiation beam on the prostate and any high-risk regions requiring treatment, such as the seminal vesicles or lymph nodes. The aim is to deliver an adequate dose of radiation to these high-risk regions to cure the cancer, while sparing radiation dose as much as possible to surrounding structures, including the bladder, small bowel, and rectum. There are different radiation techniques used to achieve an ideal treatment plan. 3D conformal therapy delivers beams from various angles to achieve the desired dose to the prostate. Intensity modulated therapy, or IMRT, is a newer technique that may offer a greater number of irradiation angles. The computer software is capable of modifying the intensity of the radiation produced from each beam. The radiation oncologist can therefore choose the best beam arrangement to provide adequate dose to the high-risk cancer areas while minimizing dose to surrounding tissues. Most men with prostate cancer will have been seen by a urologist, a surgeon who specializes in the urinary system and the male reproductive system. The urologist will offer a patient the opportunity to consult with a radiation oncologist, a physician who specializes in treating cancer with radiation. During the consultation, the radiation oncologist will determine the patient's suitability for external beam therapy, discuss the advantages and disadvantages of the procedure, and prescribe the dose of radiation to be given. Almost everyone who has external beam radiation therapy will have a planning session, called simulation, before treatment begins. A radiation therapist will use a CT scan to map the size, shape, and location of the prostate, which varies from one person to another. The images are used to pinpoint the tumor, outline precisely the area to be treated, and calculate the direction of the X-ray beams. A few tiny markings will be made on the patient's abdomen and back to help with positioning in the linear accelerator over the course of treatment. Some centers may also make a mold of the patient's pelvic area, called a cradle, to further assist with correct positioning. In some cancer centers, your doctor may ask you to have a full bladder or empty rectum for the simulation scan. This preparation can vary between different cancer centers and different physicians. Some evidence suggests that by comfortably filling the bladder, by drinking water prior to the scan and treatment, it can push the bowel out of the passageway of the radiation and thus possibly reduce irradiation to the small bowel. There is variable evidence whether any specific bowel preparation is necessary during radiation. Some physicians may encourage a particular diet to patients prior to or during radiotherapy in order to reduce the amount of gas in the rectum. Although not always possible, ideally patients should have a bowel movement prior to their daily radiation treatment in order to have the least amount of stool or gas in the rectum at the time of radiotherapy delivery. Most importantly, patients should discuss with their radiation oncologist whether any bladder or bowel preparation is required in their particular situation. In certain situations, a radiation oncologist may suggest placing small, inert seeds, referred to as fiducials, into the prostate prior to the simulation scan or treatment. Inert means that the seeds contain no radioactivity. These fiducials may serve as a means of targeting the prostate and its movement during treatment. Your radiation oncologist will explain the procedure if there is a need to place these fiducials in a specific clinical situation. Radiation doses are measured in units called centigrade, which is a measure of energy absorbed by the body. A typical total dose for prostate cancer treatment is 6,000 to 8,000 centigrade. Because the total dose is split into a number of smaller doses to minimize side effects, a patient will typically visit the radiation clinic once a day, 5 days a week, for 6 to 8 weeks. Treatments are usually given Monday through Friday, which allows healthy body cells time to recover over the weekend. Depending on a patient's particular clinical situation, there may be variability in a treatment regimen. All patients should discuss with their physician what regimen is recommended, and also understand that clinical trials may also offer regimens that differ from those described. Once a patient arrives at the clinic or hospital, he is asked to take off his outer clothing, put on a hospital gown, and lie on his back on the linear accelerator while the machine is aligned. He is kept as still as possible while beams of radiation target the prostate from different angles. The radiation therapist stands nearby, behind a window. The radiation oncologist will review the treatment program weekly or every 2 weeks. Each radiation session takes about 15 minutes to complete and is absolutely painless. The patient is not radioactive during the course of treatment, and no changes in normal routine should be necessary. The radiation oncologist will review the treatment program on a regular basis and check for any side effects. Refinements in technology and technique allow doctors to focus radiation to the prostate as precisely as possible to ensure that maximum radiation is delivered to the prostate to kill all cancer cells, while at the same time limiting the amount of radiation to surrounding structures. As precise as this may be, however, one can never guarantee that neighboring structures will not be affected. You can appreciate in this drawing that several important organs and structures lie immediately next to the prostate: the bladder, the rectum and anus, the urinary sphincter or valve muscle, and the erectile tissues of the penis. Radiation to any of these can lead to certain side effects. Ultimately, whether or not side effects occur and their severity will depend on a number of factors, including the technique used, the dose delivered, the size of the prostate, the stage of prostate cancer, whether or not hormone therapy is required, the age and health of the patient, and the patient's initial bladder, sexual, and bowel function. The short-term urinary and bowel side effects tend to follow an expected time frame. There is great individual variability of the frequency of these side effects, with 25 to 50% of patients experiencing the more common symptoms to a variable degree. Patients should discuss with their physician their individual risks, as a patient's baseline health and baseline urinary or bowel function may contribute to their risk. The majority of the early radiation side effects start at about the 2nd to 3rd week of treatment, and most of these will have improved by 6 to 12 weeks. During treatment, symptoms can be reported to a radiation therapist on the treatment unit or to the radiation nurse or physician. Typical early urinary side effects include increased frequency, urgency, burning sensation with urination, or a weaker stream. These early side effects are due to the inflammation caused by the radiation to the bladder, prostate, and urinary tube called the urethra. Symptoms relate to the initial damage to the lining of these organs, and they typically improve as the lining heals over the weeks following radiation completion. The irritative and inflammatory symptoms of the urinary tract can be referred to as a temporary cystitis, meaning bladder inflammation, or urethritis, meaning urethral inflammation. The symptoms that accompany this can mirror the symptoms of an overactive bladder, or OAB. Your doctor may suggest certain medications, diet, or behavioral modifications to help relieve these temporary symptoms if they are bothersome. You can watch the video specifically addressing overactive bladder for further details of the management. Most urinary symptoms can be effectively managed with medications such as alpha blockers, including tamsulosin or terazosin, which relax the muscle in the prostate that squeezes around the urinary channel, or by overactive bladder medications, which relax the pump muscle in the bladder to keep it quiet while it is storing urine. The occurrence and severity of bowel symptoms are very dependent upon an individual's specific radiotherapy plan. Patients in which only the prostate is treated will have a different side effect profile compared to patients where the pelvic lymph nodes are also treated. In all patients, however, where the prostate is irradiated, the front of the rectal wall receives a significant radiation dose. This can cause temporary symptoms of rectal urgency, gas, or tenderness in the lower anal area. In some patients, this can subsequently flare hemorrhoids. Patients may also experience looser stools or diarrhea, along with abdominal cramping. These bowel symptoms tend to be more common in patients receiving pelvic lymph node irradiation in addition to the prostate radiation. In these patients, there is a greater chance of irradiation to a larger portion of the colon and small bowel that can cause changes in absorption of water and certain nutrients. Again, these short-term side effects reflect the timeline of damage to the bowel lining that may start in the 3rd week and gradually heal in the weeks following radiation completion. Medications or diet suggestions may be given to you by your physician, nurse, or radiation therapist to relieve the symptoms. For further elaboration on GI side effects, please refer to the related video. While on treatments, you will be scheduled to see your radiation oncologist weekly or every 2 weeks to discuss these. Other possible symptoms include general fatigue during treatment. The fatigue can be worsened in patients who are also taking hormone therapy during radiotherapy. Due to the radiation beam passing through the skin, there can also be temporary hair loss and mild redness or dryness of the skin. Uncommon side effects of the urinary and bowel system may occur that are troublesome to patients and should be reported to the treating radiation oncologist. The urinary tract irritation caused by radiation may lead uncommonly to a urinary tract infection. Temporary pain with urination is common during radiotherapy and is not necessarily the sign of infection. All suspicious cases, therefore, should have a proper urine sample taken as ordered by your healthcare provider. Rarely, in less than 10% of cases, do men require a catheter during or after radiotherapy. Men with worse baseline urinary function or with larger prostates may be at higher risk of these. In the majority of cases, the catheter can be removed once the inflammation from radiotherapy has subsided. Also rarely, the initial inflammation may damage the mucosal lining or irritate the organ's blood vessels. In less than 10% of patients, this may result in blood seen in the urine. Bleeding from flared hemorrhoids, or more rarely, a vessel in the bowel wall, may cause blood intermixed with the stools. All of these more rare symptoms should be reported to the radiation oncologist should they occur. Though uncommon, some patients may have permanent changes in bladder function. This may include more frequent urination and a sense of urgency to empty the bladder. This can result from the fibrosis or scarring of the bladder that may tighten the opening of the bladder or reduce its overall volume. Equally, there can be permanent changes in the frequency or caliber of bowel movements. This is due to the effects of fibrosis near the bottom part of the rectum or near the absorptive portions of the bowel. Dietary changes or temporary medication can be used to manage these more moderate long-term side effects and should be discussed with your physician. For a more in-depth explanation of the etiology of bowel side effects and their management, please see the related video. Erectile function may diminish in 30 to 60% of patients following radiotherapy. There is large variability due to the age of the patient, baseline erectile function, and any additional diseases that can affect long-term sexual function, such as vascular disease or diabetes. Individual risk should be discussed with the radiation oncologist. There are multiple mechanisms responsible for the loss of erectile function following radiotherapy. There can be damage to the neurovascular bundles that sit on either side of the prostate, or changes in arterial or venous flow in adjacent structures. Radiation effects on neural or vascular tissue may take time to manifest, and it can change over the years following treatment. There are multiple ways of managing erectile dysfunction following radiotherapy, and these are discussed in a separate video. Rarely, in less than 10% of patients, long-term scarring may occur near the bladder opening, called the bladder neck, or the urinary tube, called the urethra. This blockage may eventually need surgical correction. This may be accomplished by opening up the scar in the urethra, referred to as a urethrotomy, or by removing some of the surrounding prostate tissue, called a transurethral resection of the prostate, or TURP. Due to the previous radiation, there can be increased risk of incontinence with these procedures, and a thorough discussion regarding these risks should take place with your radiation oncologist and urologist. Treatment of this complication is reviewed in a separate module. Bleeding from the urinary tract or rectum years after management is also an uncommon complication, and rarely this can be challenging to manage. The long-term scarring to the lining of the urinary system or bowel system can cause bleeding in less than 10% of patients. If a gastrointestinal specialist does perform a colonoscopy, which involves introducing a scope to directly visualize the bowel, he or she should avoid any biopsies of the irradiated tissue, as this can lead to more serious side effects. A patient should notify their doctor of their history of previous radiation treatment. Very rarely, in less than 1% of cases, serious damage can occur to the lining of the urinary or bowel systems. This can result in a permanent ulcer, and extremely rarely can cause a hole to develop between these two systems called a fistula. This results in a line of communication between the bladder or urethra and the rectum. In very large population studies, it appears that there is a very small increased risk of acquiring a new cancer in the organs near the treatment field following radiation. These cancers arise in areas that are exposed to the therapeutic radiation and may occur many years following therapy. An individual's risk should be discussed directly with the treating physician. Here we will make a quick note that in some cases, some men may require that radiation therapy be combined with hormone therapy to shrink the prostate prior to treatment. In these cases, men must understand that hormone therapy has its own side effects and may worsen or prolong sexual side effects. This subject is presented in a separate video. In summary, radiation therapy uses high-energy X-rays or other types of radiation to kill cancer cells. External beam radiation therapy, or EBRT, is one type of radiation therapy that uses a machine outside the body called a linear accelerator to send radiation toward the cancer. EBRT has many roles in the treatment of prostate cancer and can be used to treat localized, advanced, or recurrent cancer. Newer technologies, including 3D conformal therapy and IMRT, may allow even more focused treatment to the affected prostate tissue. While external beam radiation therapy is well tolerated by most men, there are some possible early and late side effects to be aware of, as outlined in this video. Your doctor can tell you even more about the specifics of your situation. Thank you again for viewing this presentation.